Recording in progress.
Hello out there in podcast land, or wherever you happen to live. Many of the listeners live in podcast land, and many live other places. It's your host, Dwight, back with you again with The Broken Brain for your weekly dose of psychology, culture, and as we're focused, we had a bunch of episodes lately about modern medicine and how this is affecting all of us. Medicine, it affects all of us. Well, hopefully. If you don't go to the doctor, you probably should. That's a whole nother episode, actually, probably, access to care, right? But today we are going to be talking about the role of AI in the way that medicine is delivered, the really kind of the philosophy and some of the things we should be aware of, particularly some of the risks that are affiliated with the use of artificial intelligence. And this is kind of a bigger conversation. Everybody can picture Jurassic Park, right? Just because we can, does that mean we should? My guest today, I was able to see her giving some sci-fi examples in this talk, which made me super jazzed even more about this interview. But I am joined today by Dr. Kristin Collier, who's an associate clinical professor, as well as the associate director of the internal medical residency for the University of Michigan Medical School. And you also head up the program about the intersection of medicine, spirituality, and religion as well, which is very, very fascinating as well. So, Dr. Collier, welcome to The Broken Brain.
Thanks, Dwight. Thanks for having me on.
Let's start out just by telling people a little bit about who you are, how you got into this wild world of medicine, and you know, what some of your interests in some of these topics are with the way medicine is going.
Yeah, sure. So, as you said, I am an associate professor of medicine. So I'm board certified in internal medicine. So that means I take care of adults with chronic illness. I'm a generalist, so I practice primary care. I've been taking care of my patients now for over 20 years that I picked up when I was an intern at the University of Michigan. And I wear a lot of other hats. I'm a medical educator. I teach the medical school. I help oversee our primary care track within the medicine residency program. And as you said, I am the founding director of a really, I think, program, the University of Michigan Medical School Program on Health, Spirituality, and Religion, which is at our medical school at the University of Michigan in Ann Arbor, Michigan, where we really hope to legitimize conversations about faith and religion and spirituality as they relate to whole person care and professional vocational identities and health disparities. And we have a variety of arms of the program. In my other hats, I'm the mom of 4 boys, and I love to cook and to crochet. So really busy. But yeah, I got into this topic of AI as someone who deeply cares about the vocation of medicine and as someone who likes to think of herself as a philosopher. I think, that the question of AI raises some really foundational questions for us that are good to examine as we think about possibly adopting this new technology into the sacred, I call it a sacred, vocation of medicine.
I love your emphasis, and I'm actually gonna plug something. Everybody can jump over to YouTube. Not yet, everybody. Listen to this first. If you look up AI in medicine, living in the new Atlantis, it's Dr. Collier has a presentation there that is wonderful as well, and I love how you get into the philosophy of it. I wanted to frame a little bit of our discussion with a tweet or an X or whatever you call it nowadays. This may sound a little alien to a lot of people out there, but a healthy tweet from Twitter, it still exists, and it exclusively on your thread, I believe, or at least you're in the contending for most healthy. I love your Twitter, by the way.
Thanks.
So this is a tweet that you made back in July 28th of this year. Anyway, I know it colors a lot for me, the attitude that I think you bring to medicine. So the tweet says, "When I was a med student on transplant surgery, we did an organ procurement from a young man. After, I was asked to sew up the incision with a thick blue thread. I was taking my time, and the surgeon told me it didn't matter, as no one would ever see it. I think about that a lot." And boy, that spoke to me when I read that. And I'm curious maybe some of the mentality there and how that ties in with your philosophy of medicine and treatment.
Yeah, no, thank you. Yeah, that experience was a long time ago now, but it is something I think about a lot. When I was a medical student here at the University of Michigan, and I was on my transplant surgery rotation, and we had taken the plane to a small northern town in upper Michigan to do an organ procurement from a young man who had died in a tragic accident. And so after the organ procurement, as a medical student, you hardly ever get to do anything except retract and sort of do some basic things. But they gave me the privilege of actually sewing up this young man in a way where, because he had obviously these incisions to take his organs. And I was taking it really seriously. And I still remember that thick blue twine almost. And I was careful and sewing and crying actually during the procedure. And the surgeon was like, Kristin, no one's going to see this. Like, hurry up. We just got to go. And I think about that all the time. And I at that time, I'm a person of faith. I didn't have the Christian faith that I have now. But even then, I think, I got a sense that, bodies matter, people matter. And there's this inherent dignity to human beings that was being revealed to me at that point, but I was just starting to understand. And all of these experiences, I've had so many experiences since then as a resident and now as an attending physician taking care of human beings who I believe have inherent worth and inviolable dignity. My philosophy of medicine really comes around these ideas of the sacredness of this patient-physician encounter, the importance of bodies. And I think about that sacred encounter between myself and a patient. I'm very, very careful. I think we should be very, very careful of who or what else we allow into that space. Hence, I am very concerned about the adoption of AI into that space, which I believe is sacred. And there's a lot at stake here, right?
There's a humanity there, and it would make a difference to me as an organ donor. I always like to say, if you don't have, if you're not in a position to give a lot, any charitable thing or whatever, it doesn't cost us anything to check that little box on our driver's license, right?
Correct.
And to think of, am I someone who is doing something for someone with a heart and a soul, personality and all that, or am I an organ receptacle at that point? And people, there are people who would argue that it's like, boy, on one hand, it's like, all we need is an organ, and that's the whole point. We want someone to get in there dispassionately and just grab it and go. I don't know if they use the phrase grab it and go much in medical school, but anyway, or am I someone who someone's going to take a minute to say, you deserve to not have a janky stitch, and you're a person who we're grateful that did something, and just that speaks a lot to me.
Yes.
I heard this term a long time ago, which is the balance between professionalism and personalism. And I don't hear people say it as much anymore. I think that the phrase whatever you call it, tending or supervising, when they're like, hurry up. I feel like our modern world embraces hurry up a little too much in certain ways. And it has all kinds of repercussions. But in the delivery of healthcare and healing, it's an interesting idea to say, well, let's hurry up. Let's just see more people in less time. And I guess that's one of the things that grows to this appealing nature, or what AI promises to do, right? Is like, oh, we can hurry up more. I don't know. To me, that's part of it. And I feel like,
for sure,
like that productivity obsession can be detrimental.
For sure. I mean, I think there is this tyranny of time that you mentioned in society that has seeped into medicine. And sometimes I'll walk through institutions and I'll see flyers for these really expensive, shiny, advanced degrees and like healthcare management and all these things, which they definitely can have some value. Healthcare innovation. But I'm like, y'all, like, the greatest innovation that we have, that we need more of actually in medicine is time. We need time, And as someone who does primary care, I'm really, really fortunate at Michigan Medicine. I take care of mostly, I would say, people now over 65. But most of my appointments are 40 minutes. And I'm just really, really fortunate to be able to have that time with my patients. Because I hear of systems where people have like 15 minutes. And again, we take care of incredibly complex patients at Michigan, and everyone has different sort of ways that they structure their templates in their clinic. But time is one of the most necessary ingredients for good care, especially if we're not going to sort of fall into, which I think is a threat, right? And one of the threats of AI, of further reducing the visit to a biomedical impersonal encounter on sick bodies instead of a personal encounter with ill persons, and to engage persons and the fullness of the totality of the way that they're suffering. That takes time. There's no shortcut around that. And I hear your point that people have said, "Oh, Collier, if you want time, here's AI, right?" I mean, AI has all these promises, but one of them is time. And I'm just skeptical, right, of the forces of the market here. Just to give a parallel example, I have some colleagues who have been incorporated scribes into their office. So this is someone, for those of listeners who don't know, this is a person actually who follows the doctor around in the visit, and they will scribe or they'll dictate the visit alongside, which can save the physician time afterwards to dictate their note. Well, yeah, that definitely saves my colleagues time. But guess what? Like, universities oftentimes will ask you, well, since we're saving you time, guess what? You got to book 2 extra patients in per half day to make up for that. So like, they didn't really have the extra time per se, because that time was grabbed by the market.
Yes.
Right.
I think that people forget with technological innovation, there's always that promise, isn't there? I mean, think of electronic medical records and I'm sure you can even go back to dictation itself, right? Into a recorder or whatever. There's that promise of more time. It frees up more time to do what you do. And by the way, we need you to do a lot more of it.
Yes.
And we need you to do it. And I think hopefully everybody out there, if you think about that, if you work in any industry that has had technology and you've ever heard anyone say that of like, look how much more time we'll have and how much this will save us. It's like, that doesn't seem, and that also, I think when we talk about AI, sometimes we talk about it as if it's already Skynet or whatever, from like the Terminator. It's like it's already functioning as this entity. We forget that no, there's people behind it, and this is one of the big problems. There's people behind it making decisions that there's already someone out there thinking, oh, you can see 5 more patients a day if this AI tool is in place.
For sure.
Even if it doesn't really work and ends up spending more time on the thing it's supposed to do. But there's someone already thinking that, and that's how they want to use AI. So we forget,
for sure,
we dehumanize the human in the process who's maybe using it. I mean, I guess this is a subjective point of view, but nefariously or at least profit driven, right? In that decision-making process.
Yeah, no, I understand. I mean, as someone who works in academic medicine, I really detest thinking about numbers and, economics and costs. And thank goodness there are people out there who think about these things. But at the same time, I, know that everyone has their own sometimes competing agendas. Like, I get it. Like, the business people have to keep the lights on. So they have their agenda. Like, I have my agenda as someone, who practices primary care, taking care of people, older people who need a lot of time. And so, I think of Leon Cass, who is one of our, still even at his advanced age, one of our premier, bioethicists in the United States and philosophers. And, Leon Cass said, medicine should never be, sort of roped into the forces of the market. And so trying to resist that. And so when I think about even the voices that we need at the tables of conversations about adoptions of new technologies, whether it be AI or EMR. I think physicians we're so busy. We've relegated ourselves out of these conversations, but we actually know what clinical medicine needs and what the stakes are very high. We need to insert ourselves in conversations with the business people to be like, hold up. Actually, this goes against the goals of actually what our healthcare system is actually set out to do. We can maybe think about some type of sweet compromise, but can we really get physicians at the table too, and ethicists at the table, in addition to the computer scientists and the business people who definitely have their own motives, but, thinking about really what the sacredness of this exam room, the stakes are high. Let's have some philosophers at the table too, and physicians.
Absolutely. If we get too lost in the idea of how do we maximize, for the sake of the program, and this is where it trickles down, because the people who do have to worry about the money most of all are the consumers, right? But I do know as a consumer, as things have happened that make me see my doctor for less and less time, I'm not being charged less. It's not like it's like, oh, here's a boon that we're going to primarily use for increased access to care. I'm not saying nobody's doing that with tech. I mean, obviously some people are. I've had a few doctors that I've interviewed recently who are using some of the modern tools and things to try to do that in their practices. But overall, I think we can all probably agree in the healthcare system, it's not like, oh, as these tools have been implemented, it's been better for doctors, it's been better for care, and it's been better for consumers. In fact, if anything, I think we're already running into how it's become given in some ways less access, even if you do have insurance or can pay your bill.
Yes.
It's like 15 minutes is still 15 minutes. It's not prorated. Let's put it that
way.
Right.
Correct.
To that model. I wanted to ask you about a term also that you use, bioreductionist, and it kind of tied in too. There's not just a different term. You can go whichever way you want, but healthism. That's also an interesting term I had not heard before until you were using that, and the dangers of these directions of thinking.
Yeah. So I have an interest in narrative medicine. Actually had a grant in narrative medicine a few years ago as I started getting interested in medical humanities. And again, for listeners who are unaware of narrative medicine, it's this branch of medicine that really seeks to understand language and stories in clinical medicine and research and education. So Rita Sharon, who's an MD PhD, she's an internist like myself. She's at Columbia School of Medicine. She's considered to be the mother of narrative medicine. And she will say that the care of the sick unfolds in stories. And I just love that. So since I've actually become aware of her work several years ago, I've been interested in narrative medicine, have this grant in it, that I won this grant, and the title of my project was Our Procedure is Talking. So my procedure as a general internist, I do some procedures. I do pap smears and some small procedures, but I'm not a surgeon. I'm not an interventionalist. So my procedure actually is talking to people. And so in that, I'm really interested in words and language. Not that I use them perfectly. No one does. But my specific interest is thinking about how language can oftentimes stigmatize certain vulnerable populations, specifically in the medical record, and how we talked with doctors. But
Absolutely.
In that,
using it imperfectly is actually a part of that process, isn't it? Because that's how people talk to each other.
Yeah. So we all have these discourse communities of language when we come together. And I'm specifically interested in medicine in particular, certain language that hides people's dignity, who we might find their dignity inconvenient. So, but within that, I've been thinking, just to get your question, thinking about how we come to see people within the clinical encounter. And I do think it's sort of a paradoxical, strange thing that, we take care of persons within clinical medicine, yet person is a metaphysical concept. And really, there's really not even a course in medical school about the patient as person. Abraham Heschel, who was a Jewish theologian, gave an amazing talk to the American Medical Association in the 70s called Patient as Person. And I just love that idea. Where is the person in the medical encounter? And instead, we've created this bioreductionism through this approach, I think, that I think sort of is naturally born out of medical education, of starting to see the patient as a bag of blood and bones, or a sort of a sick body, but not an ill person, which is different. It's ontologically different, right? Where we see life as just molecules in motion, and our job is either make the molecules go faster or slower, right? And so the person becomes completely absent from this encounter. And Heschel would say, in doing so, with this focus on sort of a bioreductionistic approach, medicine becomes disenchanted. And we do see really high levels of burnout currently in medicine. But burnout's a super complex topic, and one that has a multitude of etiologies. But part of that, I wonder, is most people go into medicine actually take care of persons, and then find themselves actually not being able to do that because of constraints of time or lack of training, or the hidden curriculum tells you to go faster. And that creates moral distress in you. So yeah, I do believe, and again, I don't think, this is a natural, I think, outpouring of there's so much science to know in medical school, right? I mean, right. Most of I train now, it's better now, but when I trained, most of the medical education I had was on receptors and molecules, right? And histology, which again, I had to know. But in that, I came out of medical school actually not even forgetting who I went into medicine to take care of, and what or who I was treating even. And this idea of safetyism and healthism, I know healthism actually is a term that's defined by some scholars in a slightly different way than the way that I use it, perhaps. But I think of often, especially with AI, and again, I think we sort of the jury is still out on this again, but how do we avoid in medicine falling into the trap of seeing health as the highest good? Now, this is a controversial statement because I think if you ask sometimes physicians, they would say that health is the highest good because without it, you can't engage in these other things. But I think in the messy reality of people's lives, oftentimes we actually do choose to subvert our health actually for other higher goods. I mean, I just saw a woman the other day who, I'll change the details for privacy, who, let's say, has a very high risk pregnancy, and she's been advised by many people to terminate the pregnancy for the sake of her health and for her safety, actually. But she's subverting her own health, actually, for the care of her in utero child, right? So thinking about this idea of what does it mean to sort of live a life that's oriented towards virtue or self-sacrifice or charity, which sometimes actually requires us to subvert our health. And think of firefighters. They're not like choosing their health when they run into a burning building to save someone, or a woman with a high-risk pregnancy, or someone going to defend their country. They're probably going to come out of that less healthy in a lot of ways, but they feel like they have done the things they've been called to do. And so I wonder how AI doesn't recognize, right, anything metaphysical. It doesn't recognize these higher goods in medicine that a lot of times are actually very important in medical decision making. And so out of an AI model of care, which I don't even like to use the word care when it comes to machines because I can't care for anybody, would there be a focus more so on safetyism or healthism that would neglect some of these higher goods that actually my patients actually very much oftentimes these are operative, and they want us to engage in a conversation involving wisdom, which machines can't have, in good medical decision making. Mm-hmm.
It's interesting. And then incorporating also, as you put it, the patient's desires, that if you look at it as I am someone who's here to tell you what your desires should be versus, because you mentioned, I mean, that's a great example of someone who's like, well, I want to try to have this child versus someone who's like, no, I do want to, I do decide to terminate the pregnancy. And having what I'm hearing, and I feel this way too, as a psychotherapist, having had similar discussions, in fact, that even exact same discussion with people in counseling sessions, right? Where we're talking about all of the nuances of their feelings of what they want and why they want it, and kind of working through that in a space where they have the freedom and autonomy to do so, right? And how do we get, do we even, number one, can we, and number one, should we get to a point where AI can begin to do that? Because that's a very human to human interaction to take that time and say, well, talk about this. What are you understanding the risks, comfortable with the risks? Great. And just as you put it, do you have your eyes open to this? And how do we know that? I know in my industry, when they do research on like types of therapy, and say which one works better than which one, because what is healthcare if not one-upping? Especially my corner of the industry seems to have a lot of that. And there's a lot of things that I use that I believe are helpful. But what methodology you use as far as a curative factor, whenever they research this, boy, it is down the list. What the therapist actually says or does is there's several components that are more important. But like in the top three, it always shows up in the top three. And I'll say number one is access to care. So if you don't go therapy at all, so we can kind of put that one on the shelf. But number 2 or 3 is always the relationship and teamwork that you have with your therapist. If you have that, it tends to work. If you don't have that, it tends to not help the goals that you came in with. And that's more important. And then the placebo effect is actually more important even than what the therapist says, as far as if you expect it to work. So if we take the patient out of the equation, so to speak, by saying like, oh, you're just a person who came here to be told something. A computer can do that. It can tell you something, and so anyway, yeah, there's a dehumanization. And then that's really interesting, as you put it, with that health as goal and how there can be dangers with that. I don't think many people don't think about this philosophically.
Yeah, I mean, I think that's why, I'm always trying to frame challenges as opportunities. And so thinking about this, I think it is a challenge for me to think about AI. And a lot of it was I'm not a computer scientist, right? But I am a physician and I've taken care of patients for a long time. But I think this opportunity of the challenge of AI has gotten me and hopefully others thinking about these foundational goals of medicine, like who or what are we treating in medicine? What are the goals of medicine, right? And we can't really think about the wise adoption of AI until we sort of think about the right goals of medicine and like, is the goal of medicine health, or what are the goals of medicine? Who or what are we treating before we can think about the wise adoption? And I love a quote just thinking about your examples of relationship. There's actually this quote by William Osler, who is an esteemed physician. And Osler said, it's more important to know what type of patient has the disease than what type of disease the patient has, right? You really need to know about the patient first to understand how to best treat them in a lens of wisdom and shared decision making. And I agree, like the computer has lots of information. Like that's not the hard part of medicine, actually. Like the information is not the hard part for me. The hard part for us, it takes oftentimes a good relationship and years of working through with patients that I take care of who have mostly incurable chronic illness, which is different than disease, right? Illness, which is a subjective experience of their suffering. Patients, machines can never understand that. And what that requires for us to understand the patient and their goals in the encounter based on their most deeply held commitments is wisdom. And, I think it was Socrates that said, wisdom is the science of right choice. So with all this information that we have, then how for the particular patient in front of me in a particular context, situated in a particular culture and time, how are we going to come together and think about the best options, right, for them at this time? And actually, sometimes the best option is actually not doing anything. And actually, sometimes the medical wisdom actually can help us not to over-medicalize normal human experience, which I, again, worry is a threat of AI or over-medicalizing human experience. And then lastly, I love that you mentioned the topic of relationship. I've been thinking a lot lately because of this idea of AI of like, what is health? And I've come to understand it as health is right relationship. And I love this idea of relationship, especially someone in primary care. Good relationship with your primary care physician also has been is found to be the most important predictor of good outcomes. Actually, there was a study that showed, just thinking about knowledge and relationship and outcomes, there was a study that looked at patients with type 2 diabetes who were adults. And they're like, how can we get these patients with diabetes to be at goal? And they controlled for all these different factors of the physician age, physician training, medical knowledge. And if you control for all those things and they were sort of equal, the number one thing that predicted the patient becoming at goal with their A1C for their diabetes actually was the communication skills of the physician. So a procedure is talking and the relationship that they have with their physician. And again, you can't enter into a relationship with a physician and an embodied person in that space in that same way that you can with a machine. There's a scholar, Katerina Gospic, I believe is how you pronounce her name, that says, AI has like all the right answers to your questions, right? But it has like the cold, like unblinking eyes of a sociopath. Like, do you want a sociopath like taking care of you, And I thought that was like a really extreme example and actually really funny, but I'm like, I don't want a sociopath taking care of me or my loved ones, right? So again, just thinking about like information is necessary, but insufficient for good healthcare.
It's because technology doesn't care because it's not alive, right? And so
it's dead.
That's why that's why you can see it's potentially not necessarily bad or good in and of itself.
Yeah,
it's how we utilize it.
It's amoral, right?
One of the things working a lot in addiction, I think people don't think of this as technology, but if you look at the technology of medication, right? Like historically. There's a lot of medications that when they came out were the shiny new toy, the great thing that's going to fix everything. And you can see that in the history of the use of cocaine, methamphetamines, right?
Yep.
Opiates. And one of the things in like the therapy and addiction treatment approach with chronic illness in particular, and I'm so glad you mentioned that, is if my goal is to feel good like I did before I got this chronic pain, for example, that's a real fertile ground for overuse of opiates. And opiates will, at first, there's a whole, pain, use in opiate-induced analgesia and things like that eventually, but where it becomes its own problem. But initially, if I take something and I feel better, that's the goal, feel better. And if it's feel better 100%, where I don't have any pain, it's like one of the biggest psychological adjustments people have to make is the acceptance of 0 to 10 pain. I'm not going to be at 0 to 1 very much anymore if I have a chronic health condition.
Right.
That's hugely hard. That takes so much kind of adjustment to try to accept that and say, if I can hit for a 4 or 5 instead of an 8 to 10 on a regular basis, my life is now so much better and I can do so much more, but I'm not hitting 0, not often, maybe never. And that's hugely difficult. And I can't see how I could go through that, as you put it, with either a sociopath or a device that functions as one.
That's right.
I mean, it's not like we don't already have problems with medicine having a reputation of being too much detachment, right? I mean with humans.
Totally.
Yeah.
I mean, totally. I think, back in the time that I trained, there was this way of teaching physicians to be in terms of their professional identity. And it was something called detached concern. So like you're concerned, but like in a detached way, and I found that to be a sort of, I would say, like a morally impoverished sort of model of care. And I think we have now, thank goodness, newer conversations about what professionalism looks like and what a professional identity can look like for physicians. But I think it's this idea too of like, yes, I think when we think of U.S. adults, and I think about especially the patients I take care of, most U.S. adults, that we see in general medicine at my place, I'm sure elsewhere, have, multimorbidity and uncurable, unfixable chronic illness, but healing can still occur, right, in these illnesses. And we need to be able to educate and train more medical students to be able to accompany patients along this journey. And it's really, I think, exciting and great. And thank goodness we have some things that we can fix and that are like very curable, and we can do that. And that's shiny and glittery and it's very attractive for our medical students. And we need those folks for sure. But what we need more of are people who are able to accompany patients through chronic illness and be able to bear witness to suffering and to talk about, how to have providers, be able to be partnered with patients with chronic illness as they navigate this, as you said, because that's very, very valuable work. And I think in my work in health, spirituality, and religion, I have this a slide that I sometimes use when I talk about like therapeutic listening, because therapeutic listening by itself actually is a therapeutic endeavor that we do with our embodied selves. This isn't something like medicine's so focused on fixing, doing, prescribing. I'm actually therapeutic listening, bearing witness to suffering can be therapeutic in its own way, or receiving a patient's narrative story of illness. And it's a picture of Job. It's like a sketch by Gustave Doré from several hundred years ago of Job and his friends. So it shows Job sitting there with his friends sort of at his feet before the friends start messing up and trying to like understand and try to blame and sort of solve his problems. And for the first 7 days, they're actually just bearing witness to his suffering. And it's a beautiful picture of like, I think of what's been lost in medicine, of this therapeutic encounter. And because machines can never understand suffering or hope or what it means to be a sister or lover or best friend, they're never going to be able to provide this care that really U.S. adults need, and that I see the need in particular.
And it's interesting as you say that, because that is in the Bible story, right? It eventually gets to where they're like, "Wow, Job, you must really be a real piece of work because of this and that and whatever," and they really blame him for his suffering. But to even take your point a step further, what does he do? He pushes back. He's able to push back because these are people who love him and he loves them theoretically.
Right.
I don't know the ins and outs of the relationship in the story, but going with it, it's like he can push back and say, no, that's not the problem. And I think that's an important component, which once again, with humans, we've had to try to train and orient around to say, well, I'm the expert. And it's like, no, the client has expertise that they bring in too. And we need to listen to that when they say, because they might either give us new information and say, oh no, I'm sorry, you got that wrong. My experience is actually this. Or they might, to your point, also say, well, I have a different goal. So are we even aligned in the goals? Yeah. Because I want to do this thing that you wouldn't necessarily recommend to me if I just said, tell me what to do.
Right.
And so that pushback is valuable too. So I like that you can extend that in that story to say, not only were they listening, but when they were wrong, he could say, you're wrong. And that could be a discussion instead of just one of the biggest fears that I would have with this is if there's a dispassionate, like detachment of not being able to have that. If I believe that if I'm whatever this is going to look like, who knows? Do I go in and I only interact with an AI unless my problem is here and there's one doctor for 50 patients who's just signing off like an insurance panel? If it's something like that and I get news I don't like, I'm more likely to just leave and not do anything and just not go back and not trust medicine. To me, that's one of the bigger risks. If the AI is like, no, we're just going to euthanize you before you leave the building. Certainly that makes a good sci-fi story, but we're not there yet. I say yet. And isn't it fun, by the way, that I said yet at the end of that?
I know. Scary. I know.
But one of the biggest risks is the disengagement and distrust someone might have if they don't feel like, because we see that now. If I don't feel like that,
we see it now.
I'm not going to make another appointment.
Oh, for sure.
Yeah.
Oh, for sure. And there's already so much distress in certain populations that it's like rightly there because of ways that certain populations and people have been treated by the medical establishment in particular. You mentioned like the technology of medication and these technologies that we've had and like this dystopian idea of you just being in some type of like sterile chamber with like a machine for your quote unquote healthcare encounter. Like, how did we get there? And I do think, which I talk about in that talk that you mentioned on YouTube, like this pathway that we've been on of the subtle removal of the physician and the patient's personhood out of the therapeutic encounter. My favorite example is like in 1816 when we developed actually Dr. Laennec, not we, but Dr. Laennec developed the stethoscope, right? So he went in and he had to examine this young woman, and he was too embarrassed actually to put his ear directly on her chest. And so out of modesty and all that, he basically, respect for her modesty, he remembered as a kid that he could sort of roll paper together to make a cone and put that on her chest, and the sound was amplified as it came to his ear. That was like the first time, right, that like this idea of like us being sort of further removed from the patient directly. And actually each technology we've had sort of has further marginalized the physician out of the way, and the patient, I would say also, because now I can just look at your numbers and I can look at your scan and so this idea of like, as you said, like at some point I've seen this model in some academic papers where it shows like some kind of triangle, and it's like a physician and the patient, which again used to be this very sacred dyad. And actually like, oh, guess what? There's actually this other line with AI, and it calls the AI like a partner in care. And it's like this triangle. And like, you can very easily imagine then all of a sudden, like the physician gets moved out of the way and it's just actually the patient and this machine. And like, I think that would fundamentally change the nature of medicine. As you said, medicine is a person-to-person endeavor, it's a healing encounter. And that makes me super sad and frankly terrified. Yeah.
Yes. When you get that, you can see how one of the risks then is that it leaves the boundary of being a tool for the patient and the physician to use, like a stethoscope, very useful. But the stethoscope isn't going to talk back, if you will.
Right.
It's not going to insert itself into.
Yes.
Except maybe this applies unless it's broken. Then it very much is inserting itself to say, well, I didn't hear anything. Now that's probably overly simplistic, but
no, yeah, it's good.
But if what if here's this other partner, that we see that's involved. It's not a tool anymore. It's now part of the team. And that is right. That is concerning. I feel.
Yeah, because as soon as you start to sort of give agency, right, to this amoral, apersonal, and as Katerina says, sociopathic entity, like you should have extreme pause about that. And I think also what you said too about this idea of like the patient's subjective experience of illness and how that informs how they view their disease and illness, and how we do or do not take that into account, and how we demarginalize that, or how we marginalize that can lead to the patient feeling like I wasn't even seen in this encounter, and then not come back, which further worsens disparities because then they don't seek care when they need to seek care. I think, Foucault, who I know is a very controversial figure, Michael Foucault talked about this medical gaze that came, right, in sort of the 18th, 19th century, where physicians started sort of looking at patients as like this object, this biomedical object. And we started to relegate patients' experience of illness. And so we sort of held up in high esteem this biomedical idea of illness and again, we can get a lot of biomedical information from a computer, and we've like sort of marginalized the patient's lived experience of illness, which is actually incredibly important. But can we reclaim both the biomedical model and the patient's experience of illness is both valid and sometimes equally, and actually sometimes the illness one is even maybe more higher elevated experiences of valid truth that we need to sort of incorporate for good care to go forth, for sure. And I think we hear from patients that they don't feel like their stories of illness are heard, or they don't feel listened to. They already feel like depersonalized with them alcohol. If we sort of start on that road, then I think, people will be like, what's the problem? Like, we don't even do that now. So like, why wouldn't we bring the machine in to do what you can even do in terms of the biomedical sort of aspects of things? Because we've set that path forward as something that like we sort of already do. But I think we should say, pause, like, yes, we haven't done right by the patients in so many ways. Let's like reset the course and let's resist this idea that AI can be a partner in care. It may have some role that we need to tease out and reclaim a space for engaging persons who aren't just sick bodies in the healthcare encounter. Mm-hmm.
Well, and I think, technology is something that increases the speed and intensity that we do whatever it is we decide to do. I mean, look at all the trouble you can get into on the internet much faster than you can get into it, just kind of IRL.
Your World Book Encyclopedia. Yeah.
Right.
Yeah.
No,
not a lot of trouble there.
And yet at the same time, it shapes, really, really good innovations too, potentially. And it's like trying to say, do we use the information? Do I walk in with this biomedical information and here's our relationship, these two people, these two experts working on something. And I have this over here. I've done a lot of training to have my expertise. We did a lot of expensive equipment and then, whatever. And I've got all these tools. Now, how about you? Let's focus on what's your expertise and how are you going to use what I'm bringing to you and how can I help you? And certainly as an educator, and this is where I think the professional is an educator and a support more than anything else. Now I'm biased because of my corner.
No, for sure.
Industry, right?
For sure.
So I kind of reject this idea, but I'm going to ask a question based off it anyway. But people talk about how, well, it's inevitable. It's inevitable. It's inevitable. I think that's kind of a cop out.
It is.
Number one, it reminds me of Thanos from the Marvel movies when he's like, I'm inevitable, and he's trying to kill half the people in the universe. And so if we just said, if the Avengers were just like, yeah, sure, I guess, that wouldn't be a very good movie. And so, is it really inevitable? But as it's there, it is here and growing. I'm curious, do you feel like there are safe frameworks and boundaries to make AI tools, whatever that's going to mean, safe, useful, instead of just doubling down on things we screw up anyway?
Yeah, I mean, I think that idea is like, well, it's inevitable. You hear that a lot around a lot of different things and sort of movements and things that I care deeply about. I've heard that argument before, and like the sense of nihilism. And I think, that I think for sure is like not a reason for us to say that like actually we could change the course of things with a lot of people coming together, of people of goodwill, and discuss what's at stake and how to best implement the tools of AI. Using sort of maybe philosophers at the table, thinking that philosophers are lovers of wisdom and thinking about that wisely. I think this idea of nihilism and like, why are you even wasting your time? Don't bother. Just stay busy, right, with the clinical work you have to do. I think, if there are sort of nefarious forces at play, which as a spiritual person, I always think that there are, wouldn't, those spiritual forces love for us to sort of buy into that lie, but like, there's nothing you can do. Just keep your mouth shut, like just keep your head down, So I do think that like, it's one of those things that we should resist if we think this is a path of high stakes, which it is for medicine. And also I just thinking of your comment of, this patient comes into the exam room and the physician is there and the patient has their, obviously expertise. The physician has their expertise and maybe AI is like this check or whatever. I just was thinking of the risk also, which we haven't talked about, the risk of de-skilling of the physician if we start to sort of outsource our biomedical knowledge into the computer. I think that's a huge risk also of AI that we haven't really touched on yet. And I think about which I totally get, our students are really, really excited actually to put like the clinical cases that we give them into chat GPT and sort of the answer gets spit out. And they're like, why are you teaching us clinical reasoning? Like, we can just put the case in and we get this answer out. And I think, there's something formative about learning how to create a differential diagnosis and clinically reason and come up with a therapeutic plan. There's that actually, like, learning is not some just like filing cabinet that you put the knowledge in the person and then you retrieve it, right? There's actually something formative about going through this process. And like, what does it mean to be a doctor? I think it comes to this other fundamental question, right? Like, am I going to be a doctor if I haven't learned to think like a doctor? And as you probably have heard, it happened pretty recently with, I won't say the name of the healthcare system, but a major healthcare system got hacked, right? And they lost like a lot of their EMR, and like people had trouble functioning because they had outsourced some of these skills. Imagine if we outsourced the skill of being able to create a differential diagnosis or clinically reason to a machine. There's something actually very, very dangerous about that. And then getting to your point about health disparities, there was a piece in Scientific American a few months ago, actually, about the further disparities that will happen with AI. If like privileged people retain like actually a real embodied physician who has the ancient skills of clinical reasoning and medical diagnosis, and sort of everyone else gets sort of the machine, right? So there's a lot of worry with that.
Yeah. As you put it, I think sometimes people think of, well, a dispassionate program would actually reduce bias. But what you're talking about is we don't have a good track history of people of using new tools to benefit those that are marginalized anyway, whether for racial reasons, socioeconomic status. I mean,
that's right.
We can look at the data already and see how people receive worse care depending on some of those factors.
That's right.
And had they die earlier, they haven't, and in fact, they don't even receive the same levels of treatment sometimes. And
that's right. Oh, yeah, for sure.
Exactly. So am I going to have is it just going to become more and more expensive concierge medicine? And I realize concierge medicine is actually an access to care model. I don't mean to diss on that part.
Yeah, no, but it's,
But you know what I mean? Like a boutique, I guess,
for sure.
is kind of what I'm trying to say.
For sure. For sure.
Well, they're very powerful things. And the really powerfulest, there we go. Part of it is that it impacts everybody. If anyone out there, there's certainly, I don't know if there's anyone who thinks that medical changes don't impact them, but when we get super excited about something new, as people are about it, do I say, wow, ChatGPT, that sure helped me do this. Wow, I gathered some research faster and I double checked and hey, 60% of it was right. What do you know? Or do I use it to write my papers? And then I don't ever learn to think about how to write a paper, right? And we amplify that up the level and see how it impacts health and art and medicine and smarts and skill building and all those things. If we don't think about it, then I guess, the negative things will increase, right? And that they'll just be there.
Yeah, no, I think it's one of those things too that, we always think that we're going to be the ones that retain the knowledge. Like, oh, we're not going to like lose that skill. And wouldn't it be sort of this strange phenomenon if, this machine, sort of causes us as physicians, this vocation is as old as time. This apprenticeship model of this knowledge has been passed down from person to person over the centuries. And we lose that to some machine. It's just outrageous. Socrates talked about that with the risk of writing, where he said, you think you'll remember, but you'll have this appearance of being wise, but you're not really wise because, you have this sort of tool that will take away this ancient sort of art of like remembering like your orations, whatever. And I think, the other thing too, that we haven't talked about, I just wanted to sort of mention is, we talked about the risk of disparities and the risk of de-skilling and, sort of this idea that, which is true, that, information alone is necessary but insufficient for good care, and wisdom is required, which machines can never have, this idea of suffering. But the other thing that other my colleagues have written on this and talked about more than I have, but I think is really, really important, is the risk of AI shaping and undermining sort of our understanding of the human person. We talked a little bit about it with sort of this bioreductionism, and as we start thinking of ourselves as machines and all that. But the risk of AI undermining the sort of idea of the human person, I think also in creating this new anthropological project, so to speak, that I think we're already sort of on, I think also has real risks. I know that's like a sci-fi idea, but actually I think there a real risk to that. When we start to conflate our own anthropology with that of machines, there's danger in that for sure.
Absolutely. Well, thank you so much for being here to discuss this. I think it's important for people to think about it. Not only those that are working in healthcare, but as you are, those that we all, by the way, whether you work in it or not, are consumers of healthcare. And so what do we look for in the way that our clinic or our doctor, and when we have especially if we have choices in our healthcare, which some have more than others, obviously.
No.
But to look for how that's being used, and maybe even have these conversations about and look for how that's being used, because as consumers, we do have some power, at least in giving feedback. So I want to give everybody a chance to know where they can find you and where they can follow your work and the important things you're doing. Before that, I wanted to ask, as I always do, if you have any suggestions for people in the ways of like the way they can do charitable or community give back in their lives. It could be a nonprofit or a charity or just a good habit. Do you have anything that you'd like to share with people?
Yeah, I just became aware of a really wonderful crisis pregnancy center, locally here in Michigan through Family Life Services. That's lovely. And also I have been a naysayer of medicine, I think, a lot in this conversation, but only because I love it so much. I do really think that in addition, for people who are interested in taking care of people, we have so many amazing programs and funds at the University of Michigan here at Michigan Medicine to take care of children and adults. So we, here at Go Blue, here at Michigan Medicine, we so much appreciate the gifts of charitable people to continue the good work of taking care of human persons who have inviolable birth and inherent dignity. So thanks. Yeah.
Great. No, thank you for sharing that. Where can people find you?
Oh, yeah. So I'm on X, formerly known as Twitter, at HSR Director, which is, I run this program on health, spirituality, and religion. So it's HSR Director. So I can be found on X at HSR Director. And also you can find me on YouTube. I don't have a YouTube channel, but I have various talks if you're interested more so in my work on human dignity, religion, spirituality, Christian bioethics, and AI. My talks are scattered on YouTube. Thanks, Dwight.
And it's Kristin with an EN at the end, and it's Collier.
It's IN, actually. It's two I's. It's Kristin. Yeah, Collier, Collier. Yeah.
That's good for me to know when I title the episode.
Thanks, right.
Probably the most common feedback I get from publicists, too. Anyway, and it's Collier with two L's, Collier.
Correct.
All right.
Yeah.
People can, definitely. And I would recommend it. You have such a good presence when you present and share.
Thank you.
There's two things to highlight for anybody out there, you listeners. Please keep in mind and remember at the end of this month, August 29th, that's a Thursday, in the midday, I'm doing our third annual live stream event for opioid overdose awareness. And you can view that. You can get the details at dwighthurst.com/live. And there will also be, the day of, there will also be a link for live, you could call it call-in, I guess, where you can join the live stream as well. Anybody out there at all can click on that and join, but there's also the links to social media where you can watch and listen to that as well. It's become kind of a fun and also important tradition to try to share that, and so everybody is invited. You too, Dr. Collier, you're invited too if you want to join.
Thanks, Dwight.
And then just one quick thing, as everyone knows, is we are highlighting a charity each month as well on the show. And this month we're doing Color Outside the Lines, which is an organization for at-risk and youth in foster care, where they use art, dance, and music to get hope and inspiration for these important young people. And that's localized throughout California and Oregon mainly. And you can go to coloroutsidelines.org to learn more about them. Or if you do join our Patreon during the month, whichever month you join, the charity that we highlight, 50% of your donations will go towards that charity for as long as you remain as a Patreon donor. So then you get the benefits on the show here. You help us out, and then also you're helping them. Or go to their website and give directly. That's fine. Obviously, that's fine. I allow it, I guess, is what I'm saying when I say that's fine. That's weird. Dr. Collier, thanks again so much.
Thanks so much, Dwight, for having me on the show.
Thank you for listening to the Court and Parts Podcast Network. To listen to more Court and Parts shows, visit courtandarts.com.
No one hates history, they just haven't found the right teacher yet. Or in this case, a nerdy best friend who loves to tell you all about world history, women's history, and weird history. Hi, I'm TK, the creator of For the Love of History podcast, a place for people who want to learn more but don't know where to start, and history lovers who want to break from the mainstream. From rat trials to warrior women, we cover topics from every country and era. Whether you're a history expert or just starting out, there's a place for you here in the Time Machine. So join me every Friday on your favorite podcast platform and YouTube for a brand new topic. See you there. Bye.